Okay. So my name's Karan Rao. I'm a structural and research fellow and PhD candidate at Royal North Shore Hospital. And today I've been tasked with giving a brief overview of conduction abnormalities post-TAVI. It's a big topic, but I'll try and go through some key kind of things in the space that have been published recently. So we've come a long way since the start of TAVI. We've got landmark studies that have been published in the New England Journal of Medicine and some recent data as well that's come out. And essentially what we know is that TAVI is safe and effective and non-inferior to surgery at quite a time after. And as of 2024, there are some different priorities now with TAVI. We've touched on this a little bit already, and perhaps lifetime management of our younger low-risk patients, as well as same-day discharge, trying to get your TAVI patient home the same day. Are priorities as we move forward. But one of the bugbears or barriers of TAVI that has existed from the beginning and is particularly relevant into these priorities as we move forward are conduction abnormalities. So we've touched on this again with some brilliant talks this morning, but understanding why TAVI causes abnormalities in conduction relates primarily to the anatomy. So there are three main landmark kind of anatomical structures to really dive into or remember: the AV node, the bundle of His, and the left bundle branch. More specifically, the membranous septum is the non-muscular thin portion of the interventricular septum that's located on the septal aspect of the LVOT and located between the non and right coronary cusps. It's particularly prone to damage or interaction with a transcatheter heart valve. And it's the fundamental reason why you get complete heart block or a left bundle branch block following TAVI. So how common is it? It really depends on what you read with what valve and what patient factors. There's a plethora of different factors that contribute to this. But if we look at the two largest available studies for low-risk patients, on the left, you've got the Evolute low-risk trial, where at 1 year, you had 19.4% of patients, almost 1 in 5 patients, needing a pacemaker at 1 year. If you look at the Edwards publication, the Partner 3 study, it was lower, but still fairly high at 1 year of being roughly 8%. A meta-analysis that was published a couple of years ago put it between about 9 and 26%. So very variable, but clearly quite a high incidence. So many people have suggested, hey, what about in high-risk patients? Why can't you just put in a pacemaker? Or why can't you put in a leadless pacemaker and then forget about the whole deal? Well, pacemakers are routine, but they're not necessarily benign. They increase the risk of dysynchrony, particularly single-chamber pacemakers. They increase mortality and rehospitalization as a result. And, well, pacemakers with leads can often interact with the tricuspid valve and lead to significant TR, again, contributing to morbidity. And if we're putting in TAVIs in younger and younger, lower risk patients, I think we have to be more and more mindful that prophylactic treatment is not really the answer. Better prediction and prevention is probably the way of the future. So left bundle branch block, which is also very common. So persistent left bundle branch block is seen in about 20% of cases. So if you add up 20% pacemaker rates and 20% bundle branch rates, you've got 4/10 of your patients having some sort of a conduction abnormality. But persistent left bundle branch block was initially thought to be a benign outcome, but that's no longer really thought to be the case. It increases, again, dysynchrony and has been linked to poorer long-term outcomes and has also been one of the primary risk factors for delayed onset conduction abnormalities or a late need for a pacemaker after TAVI. So what are the current published predictors of conduction abnormalities post-TAVI? The way I think about it is you can break it down into the anatomical or CT-derived predictors. We've touched on this a little bit today. There are some procedural factors, and then there's electrical or electrophysiology parameters. From a CT point of view, a large valve size, or more specifically, the oversizing percentage, so how much bigger is the valve compared to the anatomy that you're putting in, has been linked quite strongly with conduction abnormalities post. The calcium volume has been published with mixed data. I mean, there's some centers that have suggested that calcium, particularly at the non and right coronary cusp, can increase your risk of conduction abnormalities, and we've learned why, perhaps because of the location of the bundle of His. But this hasn't been reproduced. So as of right now, it's a fairly controversial area where the calcium volume, the amount or distribution, truly can be a helpful marker. The membranous septum length, there's no such controversy. It's now been repeatedly proven that the length of the membranous septum directly correlates with a patient's risk of needing a pacemaker post-TAVI. Procedurally, self-expanding valves have been linked quite strongly. And the primary reason for that is that these valves are taller framed, larger, tend to sit deeper into the LVOT and are much more likely to interact with the conduction pathways and the membranous septum. And as a result, the depth of implant, which links in again with the membranous septum length, the depth of implant is key. And we'll talk briefly about how there's been a push to implant the valves higher and higher, but this comes at a cost. Electrophysiology, so by and far, the biggest pre-existing predictor is a right bundle branch block. In fact, if you're getting a self-expanding valve and have a pre-existing right bundle branch block, the data suggests that your chance of getting a pacemaker after TAVI is about 40%. There's been a lot of stuff published in the field of EP, so using a multipolar catheter to get invasive EP measurements, which I'll briefly run through to help predict which patients may end up needing a pacemaker down the track. And post-procedurally, a new persistent left bundle branch block we've talked about, and PR and QRS prolongation have been markers. So we learned earlier about how CT planning works for TAVI, but one part of that is the measuring of this membranous septum. I've gone on about it quite a bit already, but it's a fairly straightforward marker to measure on CT, and it involves placing the crosshairs between the non and right cusp, and then on a coronal or frontal plane, measuring this infraannular thin portion that you can see on the image on the right. Of course, it does rely on a good quality scan as well as contrast in the right ventricle, but this is a fairly reproducible measure and has become common practice in many CT TAVI reports in centers around the world. An American group in 2019 produced this fairly seminal paper since then, where they tailored the depth to the membranous septum. So they said, okay, look, if we implant our valves above the length of each individual patient's membranous septum, they were able to prove that the pacemaker rates could come down quite substantially. And then a Japanese group late in 2023 took this a step even further, where they used intracardiac echocardiography, so ICE, which is not routinely used in TAVI, but they used ICE to measure the membranous septum in real time and implant their valves above it, and got ludicrous rates actually of 0.9% when they had quite low depths of implant, quite high depths of implant with above the membranous septum. Now, this hasn't been reproduced yet in other centers, so it's fascinating data, but whether it's practical yet, it's unclear. So higher implants do reduce pacemaker rates, but everything comes with a but. There's give and take. We learned that we're putting in valves in younger and younger patients. We have now all these techniques available. TAVI implanters have techniques available to better visualize the non-coronary cusp, the LVOT, and more accurately and reproducibly implant valves higher. However, if you're implanting valves higher, you're more likely to interact or obstruct or have problems with coronary reaccess. And if these patients in the future are going to need valve in valve, or we even heard about valve in valve, implanting higher can run you into a lot of trouble trying to get back into those coronaries. So very briefly, for the last part, I wanted to talk about EP and TAVI. Doing an EP study would add about 15 or 20 minutes to any procedure, which is a problem in itself, I guess. But groups have looked at using the AH and the HV interval, essentially splitting up the PR interval that you get on an ECG with more invasive measurements. AH looks at suprahisian conduction in a very general sense, and HV looks at infrahisian conduction. And as that table or graph shows on the right, the HV interval is a lot more stronger of a marker of conduction abnormalities post-TAVI. Groups have published that the delta HV, so that's the change in HV pre to post-TAVI, as well as the absolute HV interval post-TAVI, both can be quite predictive of pacing requirement. A French group last year published in HRS that in patients with a new left bundle branch block, so as we talked about earlier, new left bundle branch block increases your risk of pacemaker at, say, 2 years. But which patients will need the pacemaker? Well, this French group actually showed that using HV early post-TAVI can be very helpful. So having an interval over 70 milliseconds in someone with a new left bundle branch block seems to be the most useful way to use HV post-TAVI. I won't labor this point too much, but rapid atrial pacing or the AV Wenckebach cycle length, gathered quite a bit of excitement in 2019. A group out of the Cleveland Clinic were able to show that if you rapid atrially pace, so in the right atrium, if you incrementally pace faster and faster and effectively stress test the AV node post your TAVI, then you might be able to determine whether the AV node's healthy or not. And they showed that it was actually quite a good predictor, and particularly had very high negative predictive value in determining whether a patient would need a pacemaker. Unfortunately, a lot of groups then went and tried to reproduce this, and this hasn't really been done since then. So there's a bit of mixed information, but conceptually makes a lot of sense. One of the kind of biggest head scratches for TAVI is late pacemakers. So the patients that everything goes perfectly well, they have no conduction abnormalities, they go home, and then a month later are back in the ED with complete heart block. This is much more, well, it's poorly defined. What is late pacemaker? Is it after 48 hours? Is it after discharge? Is it after a week? The literature doesn't really grasp this concept very well yet, and it's less understood. We published a meta-analysis suggesting that the incidence is around 5% after TAVI, so it's not negligible. And what we're learning is that the predictors perhaps may be very different. So it makes it a lot more challenging. So if you look at that graph on the right, self-expanding valves, pre-existing right bundle, they strongly predict early pacemakers, but then fall away afterwards. So perhaps is the etiology different? Are we capturing patients that were going to get heart block anyway? It's hard to know, and definitely more work needs to go into this space. So this is my last slide, but this is the crux of my PhD, where we've done this study at Royal North Shore, where we've recruited 200 patients consecutively without a pacemaker and without prior valve surgery. And what we've done is basically looked at all the predictors I've summarized today. So we've done a CT, we've looked at CT predictors, procedural factors. It's an all-comers trial, so we're looking at both types of valves and roughly have a 50-50 split. And then we did an EP study, pre and post, and put in implantable loop recorders in all the patients. We're following them up for a year. Our last patient recruited in December last year, so we hope to present the data, early next year. So I'll end it there, but yeah, that's a whiz through conduction.